Good afternoon, everyone. Thank you so much for joining us this afternoon. I'm Shana Stephenson, Vice President of Marketing for the New York Liberty. And you are here at our 5th annual Unity Game. Today's theme was a focus on Black women's healthcare. Today's panel, presented by Empire, as well as our game presented by Empire, is titled Black Women in Healthcare, Tackling Disparities and Achieving Equity. The Unity platform was started 5 years ago in response to the many unjust murders of Black and brown people by police. And it was something that the Liberty felt really passionate about, led by our players, but supported by our organization. And we felt that it was really important to continue to amplify these issues of racial injustice within our communities and shine a spotlight on a lot of the inequities that exist within our communities. So thank you for attending our 5th annual game and panel. I'd like to introduce our panelists for the day. To my left is Dr. Teresa Smith. She is an emergency physician in the Kings County Hospital Emergency Department, and she has dedicated her training to working NYC's urban communities. Dr. Smith, please introduce yourself. Tell us a little bit more about what you do and how your work specifically supports women of color in healthcare.
So first of all, I want to thank the Liberty team for engaging the community. I think this is one of the most important things that we can do in healthcare, particularly now, with the momentum that we have in addressing health inequities. Specifically, my academic role is that I'm an Associate Dean of Graduate Medical Education. SUNY Downstate in Kings County is one of the largest training centers for physicians, and so I oversee all of that training. But more importantly, I feel like it's my passion and my calling to diversify medical education and to make sure that just as I was able to attend Spelman College, go to NYU School of Medicine, that I make sure that I pull up those behind me, people of color, women, and making sure that we have a voice in medicine. And so that is what I've dedicated my career to, making sure that there's diversity, equity, and inclusion in medical education.
Thank you, and I would be remiss if I did not say that Dr. Smith and I are Spelman sisters, as well as Denise. To Dr. Smith's left is Trixie Kioko-Kamps. She is a certified nurse midwife and currently practices at St. Joseph's Hospital in Paterson, New Jersey. Trixie, please tell us a little bit about your role and how you specifically support Black women in healthcare in your role.
I am a certified nurse midwife. I became a midwife when 13 years ago I was living in Vermont, and just by happenstance I became pregnant, and the woman who took care of me was a midwife. And at that time I had no idea what midwives were, never really heard of them. But in that time, throughout my pregnancy, and I learned about midwifery care, I felt extremely supported, loved, respected, seen, heard. I'd never gotten care like that before, and so at the end of my pregnancy and delivery, I just felt completely empowered, and I was like, this is what I'm gonna do, this is a calling. And so I entered midwifery via the route of becoming a labor and delivery nurse, with the specific goal of finding ways to make sure that there are more Black midwives. I am a unicorn. I am one out of 300 Black midwives in this country, which is shocking, considering the fact that midwifery was built off of the legacy of Black midwives as far out as the antebellum South. And we have seen that there's studies that show that midwifery care, if it's well integrated into our healthcare systems, will actually decrease the incidence of preterm birth, of low birth weight babies, of cesarean sections and other interventions. And then we also know that diversifying the workforce, just like Dr. Smith said, is an essential part of mitigating these disparities. So I am like a staunch advocate for bringing like midwifery and Black midwifery specifically to my work. And I specifically work in Paterson, New Jersey, where I work with predominantly birth-in folks of color. Yeah.
Thank you. And to my far left is Diane Nisbet. She is the Business Change Director with Empire Blue Cross Blue Shield, New York Medicaid Health Plan. She's the leading strategic initiatives to address social determinants of health for our most vulnerable populations. Diane, please explain to us what that means and how your work supports women, Black women, women of color in healthcare.
Thank you for having me. This is a great opportunity, and I just want to thank New York Liberty for the partnership that Empire Blue Cross Blue Shield has developed to address healthcare disparities. And as Shana mentioned, I am a business change director with Empire Blue Cross Blue Shield. I've been with the organizations for a year and a half. I support with leading strategy for social determinants of health, and I also support with some of our value-based payment models. Prior to joining Empire, I had 14 years of experience leading, I was director of medical and clinical operations, leading clinical programs for care management. And honestly speaking, this opportunity has come full circle for me because 20 years ago when I was in graduate school, I knew that I wanted to work in the healthcare sector, really to combat some of the systemic racism that we face and some of the inequities that we deal with in this country. And my master's thesis was on healthcare disparities for African American and Hispanic individuals in urban cities. So this is a blessing that I get to actually sit up here today and speak to all of you and truly tell you about all the great work that we're doing within Empire Blue Cross Blue Shield. We have a lot of programs in place from a clinical perspective. We have care management programs, we have quality teams that focus on closing gaps in care, and when we say gaps in care, we really mean focusing on breast cancer screenings, cervical cancer screenings. There's a whole gamut of things that we do. It's a multitude of things that we do, and again, just happy to be here, and I'll go into more detail.
Well, we're happy to have all of you joining us today, and as you can tell, these women are established in the work that they do. They're very experienced in the work that they do, but as someone who's not in the healthcare field, this topic is extremely important to me. As a Black woman, I have my own story about how the healthcare system has failed me. I've seen it with family members, I've seen it with friends, and I'm sure there are people out there in the audience that can probably relate as well. So I'm hopeful that this conversation will be informative, it'll be enlightening, but it'll also be empowering, because we want you to also leave here to be able to advocate for yourself and for your loved ones, whether they're elders in your family. So be prepared to also ask some questions at the end. We'll leave about 10 to 15 minutes at the end, so please start thinking about any questions that you may want to ask our guests. With that said, I'll jump right in, starting with a quote from our Vice President Kamala Harris. Black women in our country are facing a maternal health crisis. We know the primary reasons why: systemic racial inequities and implicit bias. This was a quote that she said back in April during the Black Maternal Health Week. And here are a few stats to support her quote. Black women are 3 times more likely to have a pregnancy-related death. Black women suffer from fibroids 2 to 3 more times than white women. Black women are 2 times more likely to have a hysterectomy than white women. And those are just stats that are related to reproductive health. And as the pandemic recently exposed, Black women and people of color were negatively affected by COVID-19 at disproportionate rates than white people due to pre-existing conditions such as asthma, diabetes, hypertension, high blood pressure, heart disease, etc. So we often hear that it's systemic, that it's structural, but what exactly does that mean, right? I think that there are probably a lot of unanswered questions, or a lot of questions that exist that we don't have the answers to as lay people. So Dr. Smith, I'll toss it to you first to help explain what that means, help us unpack that.
So when we talk about systemic and structural racism within medicine, it really means that the system wasn't built for people of color, right? And so if it's not built from the very beginning for people of color, it's automatically an exclusion. And so when you think about, and it's not just the system of medicine, it's actually society as a whole. When you think about things like food insecurity or job insecurity, how is it that you're gonna be able to take care of yourself if you can't afford to eat appropriately? How is it that you're gonna be able to pay for your medications if you don't have good income coming in on a regular basis? If people have to make the decision whether they go to a doctor's appointment 1 p.m. on a Wednesday afternoon or go to work at a job that if they don't show up, they don't get paid, that's a very difficult decision. That's a life and death decision. And so the system isn't built for everyone equitably. so that we all have access to appropriate care. Some of us who have, different kinds of insurance or even medical literacy are able to reach out, call for a doctor when we feel like something is going wrong, and investigate to see what exactly is in my body that is not acting appropriately. But other people may not feel secure enough to do that, whether it's because of their immigration status, because of not having enough medical literacy to understand that this is a problem that you need to check out. And so the system within itself is not equitable for everybody. Everyone does not have access to good quality healthcare, which means that when we have a pandemic to hit, who's gonna get hurt the most? Who's gonna suffer the most? Where there's already healthcare disparities. And so what we saw with COVID-19 and the pandemic was not surprising for those of us who are working in the community or have been working to really try to advance health access. We knew that this would happen, right? It's just, and we're another pandemic away from another disaster happening in the communities of color. And the reason being is that our system doesn't work for everyone. And so it is our job to learn the lessons that we have, and while the attention is on health inequities, to fix them before the next pandemic comes. So that's exactly what structural racism means, is that if everyone can't get good quality health care, then we have health inequities.
And one of the biggest areas that we see this exists within maternal health care. We often hear about Black women, Black mothers delivering or going into labor, and either they don't survive labor and delivery or their child doesn't survive labor and delivery. So Trixie, talk to us a little bit about why we as Black women and women of color experience those pregnancy-related deaths more than white women.
Oh my God, that's big. Well, so there's different levels to this, right? There's the systemic level, which Dr. Smith was touching on, and the systemic level incorporates things like food insecurity, which could impact your pregnancy, lack of access to transportation to get to your prenatal visits, which we know prenatal care is essential to like a healthy pregnancy. So those things, if they're not in place, then on a systemic level, you're going to get things such as that number. Black women are 3 to 4 times more likely to die from pregnancy and child-related complications than their white counterparts. But then there's the other level, which is more interpersonal, and the impact racism has on an interpersonal level. We know for a fact that the Black community just does not trust the healthcare system, and it doesn't trust the healthcare system for a reason. I don't need to spout out, everything from the Tuskegee experiment to Marion J. Sims and the fact that it was just like 2 years ago that we took off his statue. He is an obstetrician that used enslaved women's bodies without consent and to essentially experiment and perfect his obstetric techniques. And part of the reason he did that, besides the fact that he didn't value them, was he thought that he didn't give them any medication because he thought that Black people felt less pain. So that interpersonal area is where you see the lack of trust between the Black community and the healthcare system. And then there's the impact on racism on just like a literal, like the physiological impact of racism on our bodies. So we all know that like we have like the lizard brain, and it has the, whenever we're like in a like uncomfortable or a scary situation, we're going to either our cortisol and adrenaline levels like rise up, and we're going to like either run or we're going to like stay and fight. And we know
Fight or flight.
Fight or flight, exactly. Yeah, exactly. Is that what did I say? Yeah.
That's how I learned about
Fight
it.
or flight, exactly. And that's protective to us. However, there's a growing body of evidence that's showing, and I'm sure Dr. Smith, you could speak to this, is that if you are constantly stressed, such as you are living and breathing racism, you are worried about sending your kid out on the street because you don't know what his experience will be with the cops, right? If you are living and breathing that, your cortisol levels are up here all the time. And so that has been shown to have an extremely negative impact on your body. It has cardiovascular issues. It has been to some degree related to cancer. And when you take that and you take pregnancy, and pregnancy we know is our body perceives it as a stress state. So one thing that happens in pregnancy is you're automatically susceptible to blood clots because we're hypercoagulable when we're pregnant, and we're more immunocompromised. So take pregnancy for 9 months and take living in a racist society all your life and put those together, and you're gonna get what we have, which is really terrible outcomes.
So Black trauma is how it's also often referred, is literally what is slowly killing Black women, especially when they go in for pregnancy, because your body is already under so much stress.
Exactly. 100%, yeah.
I would also add that, and we're speaking about the bias in medicine as if it was something that was in the past, historical, when in fact it is actually today. And working inside the emergency department, working in the hospital, I still see bias today, right? And so we think about Serena Williams, who, when you say, I can't breathe, something's going wrong, and people are dismissing you. And so that's the other part that we need to talk about, that this is not something that's historical. It actually happens today. When you described how physicians thought that Black people don't experience pain the same way, that we have a higher pain threshold, those studies have actually been repeated, and they asked medical students that, and this was just a number of years ago, and they thought that Black people's skin were tougher, and so that they could tolerate more pain. And there've been many of studies been replicated to see giving pain administration to Black people versus non-Black people, and Black people always had delayed pain medication administration. And so this is not historical, it exists now. And so when we think about these individual acts and microaggressions and biases that are towards the patients that are coming to our hospitals asking for help, it's not even just a lack of access, but when they get there, do they get equitable, quality care?
I'm glad you mentioned Serena Williams. Beyonce is another celebrity who's gone on record and detailed her labor experience and saying that she didn't feel safe, she didn't feel cared for, she didn't feel heard. And that's a common perception by many mothers who go in and they just don't feel that the medical staff is providing the care that they deserve. Diane, talk to us a little bit about what you're doing, your work with Empire. I know that you guys have some programs in place to help care for moms, prenatal, postnatal. Talk to us a little bit about the work that you're doing.
So yeah, we're doing a lot of work in this space on both the national and the local level. So Anthem, sorry, I'm a little nervous. So quite honestly, this is, as Dr. Smith and as Trixie mentioned, this is a global issue, right? This is an issue across the United States. So we have clinical programs that are in place to try to combat this. We have clinicians on staff within our care management programs to identify high-risk pregnant moms, and we are developing national strategies across the board to address it. So our clinicians are nurses. We have nurses, we have medical directors. They assess for social determinants of health. They develop a comprehensive care plan in tandem with the medical director and with the obstetricians, and they're putting some supportive services in place for our members. So we have an OB program where we're treating those members during pregnancy and post-delivery, and then we also have a NICU program, and we're really educating parents and preparing them for discharge, because a lot of these babies are born preterm. They need a lot of supportive services in place when they are discharged home. So we're putting those services in place for them, and we're doing a lot of education with providers as well. In addition to that, we have a partnership with Public Health Solutions. They're a public health organization who provides healthcare services to families that are high risk and low income. So we actually have a partnership where we make referrals to them, and they have nurses that do in-home screenings, and they also have parenting mentors that go into the home. During COVID, we provided telehealth services to birthing moms to continue, since some don't feel comfortable with having those services in the home during the COVID crisis. In addition to that, we have a partnership with the March of Dimes. So the March of Dimes provides education to providers on preterm. Oh my God, this is so nerve-wracking.
You're doing great.
provide educational services to try to combat preterm deliveries. And our organization, our Anthem, our parent organization, we've had a partnership with them for the past 5 years where we're providing funding. So grant funding through our Anthem Foundation. We gave them $1.4 million in 2018. And we're working with local hospitals in Queens, and we have, I can't remember the name of the organization off the top of my head. There is, I can't remember. There's a program that we work with within the March of Dimes where we make, oh God. This has never happened to me before. This has never happened. So we've referred, 3,400 mothers were referred to this program for the in-home assessments, the March of Dimes. And Anthem will continue to support them financially. We've done, again, a lot of work in this space. In addition, we focus on closing quality gaps in care. So when we say quality gaps in care, we want to make sure that people are able to get in to see their providers to do preventive care screenings. So prenatal care is important. Postnatal care is important. We actually have parameters in place and goals to make sure that we're meeting certain performance outcomes to achieve quality and high performing. I don't know. I can't talk right now. The cameras. Oh my gosh, this never happened.
So, Trixie, Dr. Smith, I want you to talk a little bit about what the hospitals can do to provide better care for moms while they're in delivery. Trixie, specifically speak to your experience as a midwife. What exactly about that initial encounter you had that made you want to explore this line of work? I also recognize that a lot of Black women, particularly friends of mine, are exploring more of the doula route and midwifery and opting to have that type of care as they prepare to deliver their child. Why is it safer? Why do they feel more comfortable choosing that route than the more traditional route? I'm sure there are people that probably aren't that familiar with midwifery and doulas and what that experience provides and some of the benefits and advantages.
So there's a lot in that question.
Okay.
So I'm gonna just parse out. So what I think that the healthcare industry could do, at least the healthcare field and the healthcare sector could do, is first and foremost, I'm going to say it 100 times over, they could incorporate more midwives into their healthcare systems. They need to invest in understanding them better, and they need to invest in incorporating them and using them the way we're supposed to be used. The research has shown that midwifery, again, I'm going to repeat this, midwifery decreases the incidence of preterm birth, preterm labor, cesarean sections, increases the incidence of vaginal deliveries after C-section VBACs. We just have a system, as I was telling you guys earlier, that I work in a hospital that just doesn't know how to fully use us. So despite the fact that they have a thriving midwifery practice within the hospital system, the hospital I work for has a 43% C-section rate, which is higher than the national average. That is problematic. And again, remember, I am working with a clientele that is mostly families and women of color. So that's a shame. Another thing that I think that just the healthcare sector could do is invest in understanding, really helping people understand what midwifery is. So a lot of people will assume that midwives and doulas are the same thing, when in fact they're not. I see you. Doulas are wonderful, wonderful practitioners that are an essential part of the birthing team, but they help with emotional and physical support. They're not licensed, such as midwives and OBGYNs. Midwives, what we do, I like to just simply break it down and say that midwives are just experts in low-risk birth, and they essentially do the same exact thing as OBGYNs, except for we do not do surgeries at all. And I advocate for midwifery because the stats show it, that we are experts of low-risk birth, and we see birth as a natural part of life, and therefore we always assume that it is like normal and safe until proven otherwise, as opposed to like the obstetrics model of care, which essentially pathologizes birth. And so you're more inclined to see midwives who, because they understand low-risk birth, they understand the spectrum of it, and therefore they intervene not out of fear because they don't know what low-risk birth or what birth looks like, but they intervene because they understand that there's a deviation to something that now needs higher care. I advocate for everyone to go to midwifery, to get some midwifery care, frankly. And to your answer about like what to tell your friends, like seek midwives. Unfortunately, like I said, I am a unicorn. There's one of 300 in me of Black midwives in the country, and there's like 15,000 of us.
Why is the number so low?
I mean, it goes way back to the 1900s when basically, when obstetricians decided to take over care from midwives who were serving in the community, they essentially vilified them and marginalized them and expected them to get licensed and put all of these barriers in place to essentially like push them to the side / wipe them out. So, and then they took over. I feel like you have something to say to that.
I was just going to say, Dr. Smith, do you have something to add?
Not to that specific point, but I would say that one of the things that the hospital system can do for their patients, whether it be pregnant patients or not, before I even say that, midwives are good for everyone. It's not just people of color.
Yes.
It's for everyone. But what the hospital system can do is to engage its patients, right? And not treat patients like diagnoses. To treat patients like what they are, which is human beings that come from a family, that come from a community, and to really get to know their patients and the surroundings that they come from, whether that be the social surroundings, and we've kind of been describing what's called the social determinants of health. That's how we really can make sure that our entire communities are healthy. Do we have good food outside of the neighborhoods that we all live in? Right? And is there good access to primary care? Is there enough primary care? Are there enough midwives? Do people understand what midwifery is and how it would better help them during their pregnancy state? And so that's what the hospital system can do. And I really think that now that the attention is on the hospital system, and we have now uncovered and actually said out loud, healthcare disparity is a social crisis. The CDC recently just said that. Now it is on us to fix that. And really making sure that the hospital system treats its patients like humans and people coming from a community and engaging with the patients and asking the patients what they need. I think that is really how we're going to slowly but surely fix the problem.
I mean, that sounds a lot easier said than done when you look at the years of history that says that, it's been impossible to move in that direction where patients feel heard, where we feel like when we say that we're in pain, that they hear us. Like you said, they think that we have a higher threshold for pain, which is incredible because we're human, just like anyone else is human. Diane, did you have anything to add? Because I know that your work is literally around strategic initiatives related to social determinants of health.
Yes, so as Dr. Smith mentioned, we are focused on social determinants of health. So we do have a lot of initiatives in place where we have, we are addressing food insecurity. So we have partnerships with City Harvest. We have partnerships with the Food Bank of New York. We have partnerships with a faith-based organization that's called Tent Ministries. And I'm looking here at our marketing and our community relations teams, and they've done a phenomenal job being on the ground, literally supporting the communities when we were in the, during the epicenter, when we were, during the height of the pandemic. So there's a lot of work that's being done in this space. We are addressing transportation issues. So we do work for health insurance, I do work for a health insurance company, right? And for Medicaid recipients, they may have a benefit for transportation, but they sometimes do not have transportation to get to other appointments. If they have an appointment to complete a housing application, they can't get there, so we provide them the vouchers. So there's other things that we are addressing as well. So in terms of access to care, as you mentioned, we want to make sure that all members, even in the Medicaid space, have equitable access to care. There are myths out there that and I don't even know if it's a myth, right? It's Medicaid patients don't always get the same quality of care, and it's not true, right? So we're doing everything in our power that we can to make sure that we have a good network of physicians within our panel, within Empire Blue Cross Blue Shield, so that Medicaid recipients do receive quality of care.
I just want to add to that, I'm sorry.
Yeah.
But that's very important to know that a lot of the public hospitals, it's not lower quality of care, absolutely not. And that it's good quality of care, it's just there's not enough of it.
Exactly.
And so, we have a higher volume of patients waiting to see one lowly physician, but the quality of care that they receive is just as good as the next private hospital.
And we do see that because we do have high-performing providers who are closing out those gaps in care as we're building out those strategies to ensure that they're getting their diabetic screenings, to make sure they're getting their hypertensive screenings, to make sure that they're getting their screenings for prenatal and postpartum care and so forth.
And to something that you had said earlier, Dr. Smith, one of the other things that healthcare systems can do is diversify. Like, there is not a week that goes by where I work in a practice with 7 midwives and a handful of OBGYNs, and I am the only midwife of color and the only Black midwife there, and every week I get one client who has, they meet me for the first time and they literally have no filter and say, oh my God, I didn't know that there was a Black provider here, and can I see you on every visit, which is impossible. But like you mentioned before, that is an essential part of it, right? The quality of care for Medicaid recipients is essentially the same. It's high quality care, but something that's lacking is the diversity of the workforce, and that matters too.
Absolutely.
Just to add as well, we also have screening tools for social determinants of health. So if a member does enroll in our plan, we complete what's called a health risk assessment, and we have specific questions that we ask that are geared towards food insecurity, whether or not they're able to access health care, whether or not they're able to make it to their appointments, whether or not they have mental health disorders or substance use disorders. So we are addressing that, and if there are positive responses, we make sure that those members get referred to our clinical team so that they can do a clinical assessment and provide them with the necessary resources and supports accordingly. And then we also have a program in place as well where we're working with providers to assess for social determinants of health as well. So they complete those screening tools, and they're also making referrals via a platform that we use that's called Aunt Bertha. So I don't know if anybody has heard of Aunt Bertha. It's a social needs community tool. And we have several providers who are utilizing that platform to assist with community resources.
Did you want to add something?
No, I think it sounds fantastic. I think that if there were more insurance companies who were partnering, and hospital systems who were partnering with their patients, that again, that we could get somewhere. And I know, Shana, you said that it would take a long time, but as Trixie was saying, diversifying the workforce, right? So that your patient and your provider can come from the same culture, using the same language, that really does break down a lot of barriers. So we need to diversify medicine so that we in medicine, us providers, look like the diverse patient populations that we serve. And then teach those who may be coming from non-diverse backgrounds, right? We can all learn from one another. The first way to do that is to diversify so that we understand, this is what this cultural food means. And so, I like to give the example, oftentimes we tell our patients to decrease salt in their diet or to not have carbs, right? And if you tell a specific community and culture to take out rice out of their diet, you're basically telling them not to eat. That they're not gonna, it's not that they're non-compliant, that just means that you're telling them not to eat and it seems ridiculous to them. But if you don't know that coming from that culture, then you won't know that as a provider. And so it's on us as providers to get more knowledge about different communities and to really understand where our patients are coming from.
Diversity and representation matters. It's as simple as that. Okay, so I want to talk a little bit more about what you mentioned earlier, Trixie, about communities of color and their distrust in healthcare and participating in research studies and that sort of thing. And I know, Dr. Smith, you have some experience in that area. Talk to us about why it's important that communities of color do participate in research.
So I'll take that one first. The way that we, for example, the vaccine, right? I think that's a perfect example. The way that we know that our drugs or medications or this vaccine worked, and that's called efficacy, is by doing studies in patient populations. And for the vaccines that came out, particularly the mRNA vaccines, they had about, I think it was about a 9% in both the Pfizer and Moderna vaccine of patients who were in the trials coming from communities of color. That is a huge number, 9%, because usually that number is around 1, 2, 3%. That means that you are testing the medication that may work, but maybe it doesn't work in patients of color, right? And so if we don't have enough patients of color entering into these research trials, then we don't know if the medications will be good enough for them. We don't know what diseases or genetic components of illness are actually impacting patients of color because there are not enough patients of color entering research trials. But I understand why. And I myself might be hesitant to enter a research trial because of what has been done historically in medicine, particularly in research. In fact, I would be bold enough to say that our current medicine and healthcare system have been built off the backs of racist, techniques and methods. Henrietta Lacks is the perfect prime example where a woman went to Johns Hopkins thinking that she was getting treatment for her cervical cancer, and in fact, they were taking the cancer cells and they replicated it. And now every research lab that exists in the world, not just the country, but the world, are likely using replica of Miss Henrietta Lacks cells without her consent, without her knowledge, without her family knowing, and the poor woman passed at a very young age. So, of course, people coming from communities of color are not going to trust science, research, the healthcare system. And so now it is on the healthcare system and research to make sure that we engage with these communities and to help them understand that the protocols that doctors are using are not based off of people of color. Even things like BMI, the BMI system, which helps people to know how much to dose your medications at, right? Your BMI is how much you weigh based off your body height structure. That's based off of not a person that is my thickness, okay? So I will never be,
according to those charts.
Yeah, I will never be an appropriate BMI, and I will always be overweight, and I ride my Peloton as much as I can, right? But it's not meant for us, right? So, and if they're basing a BMI off of a body type that is not diversified, then we're dosing our medications off that body type. So we need to get more people of color into research so that how we build our medications and how we treat our patients is not just based off of one type of individual, but a diverse type of individual. But it's on us to make sure that we amend with our community from some of the historical trauma that we've caused in medicine.
So you mentioned the COVID vaccine. I'm sure many of us have friends, family members who are hesitant to take the vaccine. So for anyone here who wants to convince their loved ones to take the vaccine, what advice would you pass along?
Well, Shana and I were talking about the op-ed that I wrote. For me, it was a very personal decision, not even one being a doctor, because I myself am a human. I have illnesses, actually. I have lupus. And so for me, I really had to take it into consideration about what this vaccine would do to me and to my underlying illnesses. And that's what I would suggest for everybody, right? It's not a one-size-fits-all. It's a very personal decision, but you should speak with your physician to do a risk-benefit assessment on getting the vaccine and everything that you think may occur with that and all the side effects versus getting COVID. And for me, it became an easier decision looking at it that way. Did I want to die from COVID? Quite in fact, die literally from COVID. Or did I want to, not feel well for about 3 days? And it was an easy decision. And when I thought about it that way, and that's what I would say and encourage people to do, is to ask your questions. Whatever your questions may be about the vaccine, whatever myths you heard, or maybe not even a myth, maybe it's just something that you didn't know for yourself. You have allergies. You're trying to get pregnant and you don't know how the vaccine is going to work with you, or you have underlying illnesses like I do. How is the vaccine going to interact with your body? It's good for patients to ask those questions and then do a risk-benefit assessment for themselves.
Diane, what actions have been taken by Empire Blue Cross Blue Shield to increase vaccination rates among your members?
So we've had a lot of outreach campaigns that we facilitated. We were prioritizing by our most vulnerable members. So as Dr. Smith mentioned, we did some data mining to identify the most vulnerable populations, and we had our clinical teams, our marketing teams, reach out to those members and provide education and encourage them to get those vaccines. Like you, I had some reservation as well. I have family members who haven't been vaccinated as well. We've had, it's continued dialogue, continued education, trying to figure out, you know, what are your reservations for not having them? And then we're partnering as well with the Department of Health to assist homebound members who haven't been able to get out to get their vaccinations, especially within the senior populations. And I just want to share a quote, a statistics with you that the Department of Health just shared with us this past week. So the Black population is consistently less than 40% at least one dose vaccination in all boroughs, but the lowest vaccination rates are among the 18 to 44-year-olds. And Brooklyn is the only borough with a vaccination rate for older adults under 70%. So there's a lot of work to be done, particularly within our communities here within Brooklyn. So we are partnering, as I mentioned, with the DOH. Anyone 12 and older can get the vaccination in their homes at this point. So you don't have to go to a local pharmacy. So we encourage you to register. Again, as Dr. Smith mentioned, if you do have reservations, then speak to your primary care physicians. Try to figure out, you know, what are the pros, what are the cons. As she mentioned, I took the vaccination. I had a mild temperature for a day. But you have to, you know, think about, do I want COVID? I had relatives who had COVID, and I look at my mom who's sitting here in the first row. It was very scary when I had to put her in an ambulance. And she had a very bad case of it. So, you know, we just encourage, we're continuing our outreach attempts. Our community relations team have been out, feet on the street, educating the community. We've had community events that we've hosted in partnership with other providers, and we're continuing to educate.
I love to hear that you're going into the communities and that you removed a lot of those barriers of entries, because there are so many excuses to be made to say, like, I can't find one, or I don't, and some people don't even know the right questions to ask. So the fact that you have people that are willing to take the time to educate and inform and making it a lot easier for your members is really great. So kudos to Empire and the work that you're doing in that space. All right, so before I turn it over to the audience, does anyone have any questions for any of our panelists? Okay, great. So hold your question. Anyone else, be prepared with your question. But the final question that I have for the three of you is, I want each of you to talk about ways that we can advocate for ourselves and advocate for our loved ones when we enter the healthcare system, whether it's the emergency room or just, a standard doctor's visit, whatever it is. I think that there are a lot of times there's a lot of intimidation that may exist, where we don't feel like we have the words, we don't feel like we know the right questions to ask, and we're looking up to these doctors, these healthcare workers to really advise us, but in our gut, sometimes we know that it doesn't feel right. What they're telling us doesn't feel right, or it doesn't feel like they're providing us with enough information, or we feel dismissed, right? So one by one, each of you give us some words of advice, empower us, so when we're in that situation, we can feel like we can advocate for ourselves or our loved ones.
So I think first, just being your own health advocate is hugely important, and being a health advocate for your family members when you do enter the healthcare system. So that just even the question in and of itself is paramount. But I would say knowledge is power, right? And so ask questions. Try to understand what's going on. And even if they get frustrated, say, I need you to sit down, take a minute and explain this to me. You need to walk away knowing what you're taking each medication for, the test that was done, why they did it. You may not understand the medical terminology, but we can all communicate in English, and so can the doctors. So they can explain it to you. And in fact, it's their job to explain it to you. And so that you understand, so that you make your own decisions based off of accurate knowledge and an understanding that you feel comfortable with. So to me, making sure that you have the knowledge to make healthcare decisions. Don't put the onus on your physicians to say, well, the doctor told me, so it must be okay. No, you should know why, right? And so I think I'm really happy, you know, if we can be happy. On the one bright note of COVID is that people are now investigating and understand what vaccinations are. They're now trying to understand what viruses are and what does that really mean and how can I protect myself. And all of that knowledge will be more powerful for all of us.
I mean, you said it all, exactly. Like, that's exactly. I really believe that it's important we can't give our power away to healthcare systems and healthcare providers that don't center us. So if your provider doesn't like sit you down face to face and ask you first and foremost what is on your mind, you either flip the script on them and make sure that they start doing that, or you find another provider. But yeah, the number one thing is ask questions. I have a list of questions that when I was pregnant with my second child last year that I had, and I essentially interviewed the practices that were going to help me with my birth, like I was meeting my man, basically. That was the truth. Like, I'm not, like, this is like a transformative time in my life, and like, I'm not just going to give it up to anyone, right? I mean, I don't mean it, you know what I mean. Yeah, so like I would go as far as to like, as far as birth is concerned, ask questions like, what's your C-section rate? What's your birth philosophy? Who do you collaborate with? Do you collaborate with midwives? I was at work last week and there was a girl, a 20-year-old who called on the phone and she was just like, can you please tell me what's your C-section rate? And I was like, good for you. I was like, 43%. And she hung up. And I'm proud of her because like that is an important, like that tells you a lot about, it doesn't tell you everything, but it tells you a lot about like what is happening in that facility. And she deserves like good care. She deserves to know that she will be well taken care of, you know? But exactly to what you said, you gotta be your first and foremost, your own advocate, and yeah, figure out what questions and don't be ashamed. Like, this is your life.
Diane?
I'd echo what the others have said. Honestly speaking, be your own self-advocate. Do not be afraid to ask questions. Personally, I had an experience where I had a physician tell me, are you gonna stop asking questions and let me do my job? And it was the worst experience I ever had, and I knew this is not the physician that's going to treat me. This person does not care about me. If that ever happens to you, run through the door as quickly as you can, because there are other good physicians, like Dr. Smith, and many other physicians who will take the time to answer your questions. So don't be afraid. And the other thing I would say is, don't be afraid to ask for help. Having the courage to ask for help. People think sometimes if I'm asking for help, it's a weakness. It's not, it's a strength.
I would agree with that. I also, like Diane would say, make sure you're comfortable with your physician. I had to have a medical procedure in the fall, and I searched high and low to make sure that I had a surgeon who looked like me because I felt comfortable with her. There was a level of, I just wanted someone that I knew that could relate to me and understood my cultural background and experience, much like you spoke about, Dr. Smith. So I would say don't take that for granted. You have that right, and I would say take the time to make sure that whoever it is that you're entrusting with your life, that you have that level of like 100% trust, because it is a life or death situation, and that's something that you shouldn't take lightly. We are going to open it up for questions. I know that this gentleman had a question, and then we'll go to you. And if anyone else has a question, okay, so there's a few. So, Shana, yep, I'll let you. Who's first? This gentleman.
So my first question, it's a combined question. I know Dr. Smith and Trixie mentioned diversity in the workplace, and I know that it's a long-term situation. Do you think that it would be more beneficial to potentially have more ethnicity training for doctors and just within the medical field altogether?
Absolutely, and it's becoming more and more of a requirement by the accrediting bodies, so for the hospitals, for medical schools, to make sure that, yes, we need a diverse workforce, but the workforce that we have needs to understand diversity, right? And so it's a two-way street. So absolutely, you're right. And they are working towards that and making sure that it's a prioritization in medicine.
And I'd like to add, like cultural sensitivity training has been in place, within our organization, but we need to take it up a notch. So,
The people that are doing the trainings, are they from the,
diverse backgrounds.
yeah, those?
So usually, because that's who's tagged, unfortunately, it's usually that one person, and then you are automatically the diversity, equity, inclusion expert at your institution, because you're the only Black person. So usually, yes, they are coming from a diverse background, but I mean, I don't know what your cultural background is versus mine. Just because we're Black doesn't mean that we have the same cultural background. So, I mean, even that person still needs diversity training, and I think that's the important thing, right? Is that we make sure that our diversity training is not a one-size-fit-all, and that, we make sure that it's truly diverse.
And to your question, which is a really good one, like my healthcare practice, they just incorporated undoing racism into our program. Like the entire obstetric stream was expected to do it. It was fascinating on many levels. I think the most important thing that came out of it is there were practitioners that I work with that had never actually identified as white allies, but actually they realized that they wanted to learn more, and they wanted to they were just stunned at how essentially racist our obstetrics team was, and they wanted to play a part in starting to work through that. And so it was nice to know that just because I was the only Black provider there, it didn't fall all on me. It was really nice to have these trainings identify people who are willing and able to take up that torch and speak to their own people, about it.
Hi, I just want to thank the panel for such an informative discussion. I am in fact an OBGYN. I have been in practice for over 23 years, and I'm actually the chair of my department. And I'm also the Diversity, Equity, and Inclusion Officer. So I completely understand what you're saying, Dr. Smith. I just want to just throw out a few more statistics. So what VP Harris has said in terms of maternal mortality for Black women, which is 3%, that is not the case for New York State. For New York State, it's 5 times more likely, and for New York City, it's 8 times more likely. So these numbers are quite dramatic. And so we have to kind of reimagine a way that we can inform respectful care and also self-advocacy, but also holistic approach, which is inclusive of midwifery and also doulas. And so I work on several different task forces to make sure this happens, but it is a monumentous task. So I thank you for having this discussion, and I applaud you all.
I wonder if there's any sense of optimism that more women of color are going to become physicians in midwifery or in the healthcare system, including research too, and if there are some good programs going on to make sure that recruitment is happening.
Oh, absolutely. There's always optimism. I mean, and my Spelman sister can attest to this. Spelman College is the Black Girl Magic Center, and so we're coming. And I'll add Morehouse as well, our brother school. But no, I mean, because we were excluded from entering the medical schools, we had to build them ourselves. And so Meharry, Howard, it's not that we're not there. It's just that we need to make sure that we are elevated and that we are in positions of power to keep pulling more and more people into medicine. So there are many, many programs, too many to mention. There is, prioritization, as I was saying before to this gentleman, to make sure that there's diversity in medicine and that we are recruiting, such that accrediting bodies that accredit medical schools, that accredit residency programs, are making sure that we diversify. It's just going to take generations upon generations upon generations. And it just doesn't start at the level of even college or medical school, because how do you get into college, right? You need to have coming from a good educational system from elementary school so that you know the opportunities that you can have, so that you're getting equal amount of education, quality education, so that you can pass the standardized test to be able to get to these higher levels of education. So we need to reach far, far, far back. But it's happening, and it's been happening. But now that there's so much attention on it, maybe companies can put their money where their mouth is to say that, you know, they not only appreciate diversity and inclusion, because that's the catchphrase now, we appreciate diversity and inclusion, but they practice it. And we need to go from appreciating to practice. And so hopefully that will help to really increase our numbers.
Fellow midwife here in the audience too. I think part of the bigger issue in that, right, in recruiting and bringing more people of color into these fields of medicine is understanding too the actual monetary costs of training people. So you could come out of midwifery school, which is a nursing degree, midwifery degree, like 100K plus in debt. So when you're thinking of what these jobs are paying providers as well, where you might come out and make, if you're lucky, 90 grand in a city hospital as a midwife, like it does not compute. So a lot of companies and individuals, like if we're thinking about reparations in a bigger form of this, right? Like that's one of the best ways I think that we can think about the idea of reparations is literally pouring money into creating practitioners of color who will truly be the people on the ground. And then as white allies too, thinking how can we support that as well, right? Am I encouraging these people to be colleagues together, right? Am I part of the problem in not making people want to come into this profession because of how they might be treated? So I know in my particular practice, we're working really hard on introspection, how we treat our patients of color, how we treat our midwives of color, and it's a reckoning and it's hard, but that's a huge piece of how we can fix this gigantic problem.
Great idea.
Hi, I'm the Director of Marketing for Empire, and I just want to say what a great job all of you have been doing. Diane, you're awesome.
I was so nervous.
Dr. Smith, I did not go to Spelman. I did go to Lincoln, unfortunately, but I did not go to Spelman. But I did have one question, and looking from a guy's perspective, right, in this process and supportive. And so I've had 2 children, and they both have been C-section. And so we were told that the reason for the C-section sometimes has to do with the pelvis and things of that nature. And I never really knew if that was rumor. And I always wanted to ask somebody, so I felt like this was a great time to ask this great panel that question to see if there's any truth behind that and get your thoughts on when people are told things like that.
Do you want me to answer? So there's 4 different types of pelvises that a woman can have. And so certainly there are types that cause what's called cephalic pelvic disproportion, which then does not make a vaginal birth achievable. So that can be the case. I don't know if it was the case for you, but that is a plausible reason why one would have to have a C-section.
Did you have a question? No? Did you have a question? I saw your hand earlier. No? Yes, you have a question.
Good afternoon, great presentation, y'all. The question I have is around health plans and you mentioned about the quality of care. Are physicians and providers compensated at the same level of coverage, whether they're a Medicaid patient or a commercial patient?
Yes, we have one salary, so for the most part, it really doesn't change based off of coverage. How the hospital systems or private practices in themselves are reimbursed are dependent on that, on private, patients or coverage versus whatever is public. So yes, but ultimately does it impact a physician's salary? For the most part, particularly when you're looking at the public hospitals, no, it doesn't. So I know that there's a misnomer that, physicians, that's why we want to see so many patients. We want to see so many patients because we get paid per patient. Or I heard things like, the more people that got vaccinated, physicians were getting paid per vaccinated patient. None of these things are true. It's a salary. So whether I see, 5 people or 100 people in the day. There is some reimbursement that's tied to it, but it's usually the structure, not the person's salary.
And And the other?
And just to add, I can add to that as well. So we have some value-based contracts in place, and what that means is that providers are held accountable for performing. So there are quality parameters that they have to meet within those contracts, and we look at utilization trends. So we want to make sure that primary care physicians are managing their members accordingly. And ER utilization should decrease. Inpatient utilization should be at bay as well if they're managing their members appropriately, and they're not. Honestly speaking, if members are going into the ER at a high rate, then they're not visiting their PCPs, and PCPs need to be held accountable for that. PCPs, by the way, acronym is primary care physicians. So we have those payment models in place to hold providers accountable. And what we do is we look at our network. We look to see who's high performing, who's low performing, and if you're a low performing provider and you're not meeting those parameters, you may not get incentivized if you're not meeting your quality requirements. So they'll see something, again, you work for Kings County, Downstate, but we do have those payment models in place and those contracts in place to address it.
Yeah, that was my question. Thank you for that. It was just more along the lines of what the state standard of care for all, because everyone's health plan is not the same.
Right.
And so just I wonder if, with the payment incentive for physicians and the health systems and primary care practices, are they compensated appropriately in order to provide the same standard of care based on the obstetrics benefit?
I mean, that's a great question. It's absolutely a great question. But if they're providing good quality, it's the opposite though. That's what she's basically saying. If they're providing good quality care, then they will get appropriately compensated.
Exactly.
And so just recently with the ACA, right, which is what, Obamacare, that is what they put in place. That you have to provide the good quality metrics. Everyone has to, so everyone gets compensated accordingly. Now again, it usually doesn't necessarily trickle down to someone's salary on that granular kind of a level. It's usually the system or the practice, but that's their company. So if their company is not bringing in money, if it's a private practice, then it is, gonna impact them. But that's how it works, so that everybody makes sure that everybody gets quality care. Whether you're in a public hospital or a fancy private hospital, you get good quality care.
Absolutely.
And we even have performance scorecards. So we have performance scorecards that we generate that we share with those providers who are in these value-based contracts on a monthly basis, so they can see their trends over time.
Thank you.
We'll take 2 more questions.
Thank you, Shana. So, good afternoon, everyone. Manisha Franklin, Director of Community Relations at Empire BlueCrossBlueShield. And again, Diane, you did a fabulous job. As a Director of Community Relations, I know, and my team and my colleague here, colleagues all around this room, is that it takes a village, right? We know the impact of inequality in underserved, disadvantaged communities that we serve on a daily basis. So at Empire, what we've done, as Diane mentioned earlier, is we meet our community, our members and consumers where they're at. So we have teams that go out, and they were out earlier on the concourse, giving information, sharing information about the products and services that Empire offers. Setting up pop-up clinics, going in communities where immunization and vaccination rates are low. So again, I want to applaud New York Liberty, which is another reason why our parent company, Anthem, has made a decision to dedicate not only financial resources, but human resources. People that look like the communities that we serve. And we know we can't do it alone. It takes a village. So again, thank you so much for the partnership, and we look forward to working together to combat the issues that we have in Black and brown communities. So thank you.
I promise this is my last question. So it's to Diane. The incentives in which you guys have in the contract for the doctors, and I'm pretty sure Dr. Smith can also jump in with this. Do you feel that it affects the quality of control, not the quality care in which the physicians impact on the community with those incentives being in place?
So do you mean when you say it affects the quality of care?
Right, so for instance, I'm a doctor and I have to meet all of these lovely guidelines, and if I don't, it's impacted by me not getting this amazing gold star. Let's just go with the gold star. And now I really wanted that gold star. So in order for me to get that gold star, I'm bypassing all the other things and I'm just getting straight to the gold star. So do you feel like the incentives affect that?
You have to meet those parameters within the contract in order. These parameters are in place because we want to make sure that providers are providing quality care, and they're the gatekeeper. Primary care physicians are the gatekeeper, right? So they're supposed to manage their members holistically. If members are, yeah, they're supposed to, exactly. So if they don't, and their members are utilizing the emergency rooms because they're not seeing their primary care physicians and their primary care physicians don't do a good job, those contracts that we have in place with those specific providers, they won't get paid because they don't meet the parameters within their contract. So if they're a low performing provider, right, we will evaluate those providers, right? We will literally work with them, educate them to get them to a higher performing status. But they won't get incentivized if they don't close out gaps in care, if they don't meet those parameters, the way those specific contracts are designed.
Right.
And again, it's not with every single provider that we have within our network, but we have some basic contracts that are in place. And we have what's called, I'm not gonna get into all the ins and outs, but there's risk contracts, right? So providers are taking risk with us, and if they don't meet, there's downside risk. They won't get payment.
But those markers are basics. They're not anything special.
Exactly.
It's not fancy. It's like, don't, write the appropriate prescription for your patient. Check. Like, say hello. Check. I mean, it's like literally the most basics of basics. It's not something that, this is the care that you should be receiving. So the markers are set up for you, the patient, to make sure that everyone gets that quality care. And that's not, this is recent, by the way. It wasn't based off of quality metrics. This is what Obamacare did, was to make sure that we put the incentive not based off of other things like, how many CAT scans and other things that you order, but are you ordering a CAT scan for the appropriate reasons? Not just because we have the big machine there that maybe will answer a question. And so these are very minimum basic markers that every interaction with the patient should have. So it's not like it's something that it's a stretch for the doctors to meet some of these things. And if they're not meeting it, then that's a problem with the system, whether it's the private practice system or the hospital system that they need to fix. So them not getting paid the money is probably appropriate.
Thank you for your question. That concludes our panel. Thank you to everyone who attended today.